I'd like to welcome everybody to our side event, and could I ask you to take your seats? We have two panel discussions on universal health coverage and pandemic preparedness, and a very important launch of a Young African Health Innovators Award. So I'm rather keen that we start on time, ladies and gentlemen. And let me just say to everybody, welcome, especially welcome to our remote audience, as well as everybody here in Geneva for our event on the side event, one of the many side events at the World Health Assembly. My name is Claire Doul, and I'm your moderator. And as you know, if we're to achieve universal health coverage, and that's a key target of WHO and the Sustainable Development Goals, we're really going to have to strengthen health systems. And to do that, we're going to have to innovate. We're going to have to innovate in research and development, innovate in financing, innovate in regulatory pathways, and of course, empower communities, because it's all about ensuring access and equitable access to all. So before we start, it's my great pleasure to ask Amadou Diarra, Council Chair of IFPMA, to say a few words. Please.
Thank you very much. I hope everybody can hear me. Yes? Okay. So, Excellencies, distinguished speakers and guests, dear colleagues, it is a great pleasure to say a few words of introduction before we dive into the topic of universal healthcare, pandemic preparedness, and the role that innovation can play to address both. As we speak today, we're still grappling with the impact of COVID-19. Of course, there is a human cost. I will not debate the numbers, but some say it's above 7 million deaths. From an economic standpoint, the lost output has been quantified to be 28 trillion. It's a lot of money, honestly, whether it's more or less. It is over what I can count myself. In terms of the cost that it has taken to actually respond to COVID, it is evaluated to be $11 billion, 500 times what it would have costed to prepare for COVID. So it is a clear case for pandemic preparedness. I would say that we've lost a lot during COVID. The gains that we had from a global health perspective were lost both from non-communicable diseases and from a communicable disease standpoint. And this has affected the world globally. So what have we done? I think there has been a number of successes, among which the ability collectively to bring vaccines, therapeutics, diagnostics to the world. And just to put a date on things, or a timing on things, it has taken 326 days to bring the first vaccine after the genome of the virus was made public. When everyone remembers that such a meeting couldn't have taken place, and I'm talking about this meeting here, but we could broaden the scope to the World Health Assembly, we realized that we are fortunate to have, these solutions coming thanks to innovation. But let's remember that whether you look at the mRNA technologies or vector-based technologies, these have been in the works for decades before the occurrence of COVID. So it tells that innovation needs to flourish in a context which is conducive if we are to be prepared and respond as quickly or quicker than we have responded before. So I belong to an industry which is playing its part We want to be part of the solution. And as I was saying this morning during the launch of the Global Breast Cancer Initiative, how do you eat an elephant? It's bit by bit, but with the right expertise joining hands. And I think that this is what we have on the panel here. I think this is what we have in the room. I just want to call your attention to something which is important in my view, which is the document prepared by IFPMA about the lessons learned from COVID-19. This document is available outside, but also online. And I think it is a good way to look at what we have collectively accomplished and what would be the areas of opportunities in terms of improvement. Added to that, IFPMA has worked hard with other stakeholders, including WHO, to socialize what we call the Berlin Declaration, which is a proposition for joint approaches to be better prepared for the next pandemic. So enough of hearing me. You have to now listen to the real experts. I know how to talk about what I have read and heard from others, but you're going to hear from the right experts now. So thank you very much for coming as numerous as you are, and I look forward to a great discussion. Thank you.
Thank you, Amadou. And as Amadou says, we've got two panels, one on pandemic preparedness, but we're going to start with universal health coverage. And I would really like to ask you to use these hashtags for any social media posts. Hashtag health for all and hashtag innovation for health. And if we start on universal health coverage, I expect you saw that WHO came out with some new data today, and it's good news. They said that since 2018, an additional 477 million people have access to universal health coverage. But of course, we need to do much more if we're to meet that 2030 target. So let me introduce you to the panel of innovators and enablers. At the far end, we have Farid Fezoua, Global Director, Health and Education, International Finance Corporation, World Bank. Welcome. We have then next to Farid, Anne Vermeersch, Vice President, Head of Global Health Access, GSK. Next to Anne, we have Leanne Pusey, Executive Vice President, Corporate Affairs and Communications of Eli Lilly and Company. And then next to Leanne, we have Hiti Silo, Unit Head, Regulation and Safety at WHO. And Hiti was previously the Director General of Tanzania's Food and Drug Authority. And sitting next to me, we have Caroline Bindio, CEO of Amref Health Innovations, and that's Africa's largest health NGO. So we're going to hear about innovation and how we enable that, and it's all about strengthening health systems. So Farid, if I begin with a couple of questions with you, because you've got extensive experience in health project financing in low and middle income countries. So very briefly tell us, what's your approach to this when you are looking at financing in these countries?
Thank you, Claire, and thanks for having us here today. I would say, UHC is definitely a broad topic, and I would say even if WHO came up with good news, there is still within the financing piece a huge gap, because we reckon that there is probably still for the 54 poorest countries something like $180 billion gap still in funding to attain the SDGs. So it's definitely a topic that we're involved in from the World Bank and the IFC. And within the UHC, there is always the demand side and the supply side. It's not just one-sided. And the demand side is about helping the countries to develop their own funding mechanisms, whether it's a national insurance scheme, and we're still lagging in many places on that, to make sure that the countries themselves can fund that part of the equation. And then there is the supply side, which is really what we're, from an IFC standpoint, enabling, which is the private sector oftentimes health service providers. But I would say the overall healthcare system, and we've seen with the pandemic that it's not just, delivering health, it's about local manufacturing, it's about creating the local supply chain and making sure that this is sustainable. So within IFC, alongside with many other DFIs, and some are probably in the room, alongside with many other agencies, WHO represented here, but also many other agencies from Gavi to CEPI and others, particularly on local manufacturing of vaccines and drugs. This is something that we're trying to provide the adapted funding solution. So how do we create I would say the commercial lending that takes all these private operators to create commercially viable and sustainable model is key, because otherwise that supply side can work for 6 months, a year, 2 years, but then it disappears if it's not really viable over time. So we focus on that. We bring together, because as the World Bank, we can be that catalyst that blends financing from commercial financing and donor and grant funding. We act as a trustee in this regard, and this is something that is much needed, particularly when we're tackling UHC and access in low and medium income countries. The last point I would make, in the midst of and that's good news, I think, because in the midst of the pandemic, we kind of all rushed to create the right capabilities, particularly in low and medium income countries. We spent billions of dollars, we mobilized, and I think that was the good news. But we focused on emergency, on response. Today, if I look at the 4 billion global health platform that IFC put in place in 2020, that was mainly designed to that response, we kind of pivoted to position this funding. We deployed about 2 billion year to date, and we still have 2 billion to deploy, but really to create those capabilities while we don't have a pandemic pushing us in localization of capabilities. And I think this is very critical, because without regionalization, without localization of these capabilities, I don't think we can face any kind of future pandemic. We cannot create response for the next burden of, well, it's already there, of non-communicable diseases. And more importantly, we're not creating a path to UHC. So that would be my take on what financing can do.
A lot to be done, and as you say, it's about doing this during peace times as well as when you're in an emergency. Let me turn to Anne from GSK. What do you see as your role in strengthening health systems, and why is that important?
Yes. So first of all, thanks for inviting us here tonight. And if you say, why is health system strengthening important for you? It's very clear that as GSK, we have been leading on access to medicines for so many years. We have been supporting health system strengthening initiatives for so many years, so it's clear that it must be important for us. And why is it so? Well, first of all, of course, as industry and innovator, our first role to play is to bring new innovations to life. And as part of our global health ambition in GSK, actually we really want to focus on reducing health inequalities by really trying to change the trajectory of high burden infectious diseases that disproportionately affect lower income countries. And we want to do that first of all by investing in R&D, also by working on access programs, and also by doing health system strengthening. But first of all, on R&D, I think this is where it starts. We want to develop new products, and last year in Kigali we made this commitment that over the next decade we will invest 1 billion in R&D for malaria, TB, and HIV, and this is a big thing, but it's only just one step. Once we have that asset available, of course, it will only make an impact and help reduce health inequality if it really reaches the people who need these products, and if the programs are implemented. And that's why working together with partners to strengthen the health systems, it's so important, so that at the time we make a product available, there's also a pathway to access. And so over many years we have been working together, for instance, actually long partnership with AMREF, one of the other speakers on the panels earlier, who you will hear from later, but to really work together with MREF, local partners, local governments to strengthen health system by building capability, by training first line or frontline healthcare workers, training on infectious disease, but also on prevention, on mother and child health, and all of that to ensure that people have better access to this primary healthcare service, where it all starts.
Yeah, absolutely. No good developing products if you can't get them to the people, as we will indeed hear from Caroline. Now, I think it was a few months ago, was it last year? It certainly hit the headlines that there was a new malaria vaccine that you've come up with, and you've now got a TB vaccine candidate in the pipeline. So, I mean, what lessons have you learned from the malaria vaccine in terms of, you know, going from the laboratory to market access?
Yeah. Yes, first of all, of course, we're very proud that after 35 years of research and partnership, finally there is a first malaria vaccine that can be made available and will start to be rolled out beyond the pilot later this year. So that's, of course, a huge success and also a scientific breakthrough that there is finally a first vaccine against malaria. But 35 years is also a very long time. And so if there's any lessons to be learned, and I think clearly COVID also learns some of those lessons, is that we should be able to do this faster in the future. And in order to do that, what's needed? And we believe that, first of all, it's a multi-sectoral approach and it's working in partnership. That's really where it all starts. But then with these partners, what's absolutely key is that you really have one aligned and end-to-end plan. So from R&D up to access, really thinking through what's the role that every partner needs to play and to be aligned on one objective together. I think that has worked quite well on having this vision together, but still I think the work was very sequential rather than in parallel, which I think, again, was something that COVID really has pressured us to do better. And why that working together on one vision is key is because you really need to not only do R&D, you need proactively to think of policy implementation and all of the steps that follow. A second key learning for me is very early on working together with the implementing countries to build awareness of the disease, but also build local ownership. And one key way of doing that is through capability building. So for instance, in the malaria program, we did a huge phase 3 trial in 11 sites across 7 sub-Saharan countries. But while doing the clinical study, we invested in capability building for clinical trials, invested in pharmacovigilance system. And that, of course, also helps to build awareness, but also start thinking ahead of how can we implement this vaccine, which will certainly now help the implementation phase, which is coming up. And also, I think we clearly see that governments are very, I would say, involved in this program already. So I think low engagement in the implementing countries, capability building is key. And then last point, but not least, and you referred to that, is this is a very big endeavor, this R&D investment in these programs, malaria, TB, very, very complicated, HIV as well. So those are high-risk investments. And I think for industry to be, I would say, encouraging companies to continue to work in those fields, I think it's really important that there are solutions for risk sharing, but also market shaping initiatives so that stakeholders are very clear on what a solution needs to look like, what works, what is not working, how a procurement mechanism can be worked out so that, again, once there is a breakthrough in R&D, that there is also a clear pathway to access, and so that those investments can really translate into health impact.
Yeah, some of the lessons learned from COVID about these regulatory agilities that we'll hear about on the next panel, yes, where it should not be sequential but parallel. So there we are, very exciting news. Hope that that malaria vaccine is going to get to the people. Let's move then from infectious diseases to non-communicable diseases. There was some more WHO data I saw today, but it wasn't such good news. It said that they now account for almost 3/4 of all global deaths, these NCDs. So, Lee, you're going to talk to us about not a new product, but a new approach to getting treatments in this space to those who need it. Tell us what you're doing.
I'm excited about it, but thank you for having me. And I think you're going to hear some similar themes down the panel here. I doubt there'll be too much mass disagreement here. I think the importance of R&D and innovation remains as needed as ever, but that has to be matched with reach and access for patients. And at Eli Lilly, we've had diabetes at the core of our mission for 100 years or more in that space, and we continue to pursue that innovation and those breakthrough outcomes because we still haven't got the full cure. We're managing it, and we're helping people. We want to continue to help patients manage that. But it's not always affordable, and it's not always accessible, and that is an equal commitment for us. And in fact, our journey in this particular space started back in 2016 when we launched a program called 30 by 30, where our goal is to reach 30 million people annually in limited resource settings by the year 2030. And we've targeted that through 3 different programs, and it really was our charge to do this with an eye towards sustainability. In other words, not just perhaps providing resources, which are critically important, but leveraging that expertise along with resources, and for us in a couple of ways. One was with the pipeline, which we've talked about continuing to invest in either in our house or in others that are looking to really go after unmet need. The other area is in programs, and programs that are really designed to address access. I'm going to come back to that. And the third was partnerships, and those are perhaps more familiar to us, where we're really trying to strengthen those local communities for that holistic approach to the healthcare that is so needed in LMICs in particular. And so longstanding partnerships with Life for a Child and with Direct Relief and others whose mission is to really help improve that healthcare system. But let me come back to programs, because more is needed, and since we're all throwing out numbers, I also, I think a number probably well known to this audience, but we have 24 million people living with diabetes in Africa today, and that's anticipated to reach 54 million people by the year 2045, I think it is. That's a 134% increase. So our work is not done. We can have these programs, but Lilly and I think other companies really committed to trying to drive better access. So we needed the sustainable. It's another term we've talked a lot about. How do we do this in a sustainable way, in a sustainable supply? So one of the programs we were able to announce, it's an initiative that we partnered with EVA Pharmaceuticals in Egypt. And we announced this back in December. So it's a really tangible example, along with the ones An had, about really going local, partnering with a well-qualified, state-of-the-art manufacturing team that has reach in Africa, in 56 countries in Africa, in lower middle income settings in particular. And we're going to partner with them. And Lilly will provide the API at cost, and we're going to work with them on technology transfers. But this will enable them to really produce locally and deliver locally. And we feel like that's important because they know that community. They know how to best meet those needs. So it's a great example of that kind of a partnership that we're talking about up here. And our goal with that partnership is to reach 1 million patients in 56 LMICs by the year 2030 as well. But I think I'll just put one more plug in case I don't get the mic again. And that is just to say that I think we're all echoing this. We cannot do this as a company or even a company partnered with an entity like EVA. We need to have multi-stakeholder engagement. And I think, again, we've talked about the financing piece of this. The healthcare delivery system has to be strengthened because in Africa, for example, less than 50% of the people living with diabetes are even aware of their status. And once they're diagnosed, being able to get to that care, or much less be able to afford that care, because a lot of it is out of pocket, is really a huge barrier, obviously, to their being able to meet those needs. And so there's a role in the financing and the healthcare delivery and some regulatory. So maybe we can come back to the regulatory piece.
And I was going to ask you about that because you say you're starting that partnership with EVA in Egypt. And have you got to the regulatory process yet? Where are you and what sort of experience is that?
Well, we're very encouraged. So maybe we'll have to come back with the experiences. We're still in early days, but very encouraged by the WHO's focus on creating this pre-qualification pathway that we think is very helpful, I think, to sending the signal that we are serious about trying to expedite these medicines to the patients most in need, and not, because it's only part of the solution, as we've said before, to innovate these medicines, but if we can't get them to patients. So we're excited about that. That in turn, and I'm no expert, but I know we have one on the subsequent panel here that is to speak to that pathway, but in turn partnering with regional and local governments to really accelerate, and regulators to really help accelerate those approvals so that we can get these medicines to patients is the goal.
Thank you. And, well, let's stay with regulatory. Hiti, you're not responsible for pre-qualification, but you are responsible for national regulatory systems. And, of course, you've got to build their capacity to facilitate this access that we've been talking about. So how are you doing that? What sort of things?
Yeah, thank you. And thank you for having me, and very good afternoon to the audience here. So first of all, to start by saying that the work that we do is actually guided by a decision of the Health Assembly in 2014 when they adopted Resolution 6720 on regulatory system strengthening for medical products, and also calling for WHO to support countries based on the expressed need by the member states. In this resolution, it was also clearly articulated that any well-functioning healthcare system will be very much dependent on a strong regulatory capacity. And that's where we come from, and therefore also to add here that we see that the Sustainable Development Goal, particular target 3.8 on UHC, can also be achieved if there are also strong regulatory systems in our member states. So for that, we have been working with the member states in terms of supporting their regulatory capacity using the WHO Global Benchmarking Tool, which is a unique tool that has been accepted by all our member states to guide them in terms of addressing regulatory gaps of course, in countries. And this tool was introduced in 2016, and as we speak today, it has been used in assessment of 95 member states. Out of this, 60 have undertaken their self-assessments, and 35 have actually undertaken a formal assessment by WHO. And there has been quite a significant progress in the last 5 years, where we have actually, within these 5 years, we have been able to see 12 of our regulators achieving maturity level 3 or 4, and out of this, 6 were announced actually last year. So this is a major milestone, and of course, and of course, out of these 12, 6 are in the African continent. I think most of the panel speakers have also spoken about Africa. So we are doing a lot of work, and in fact, in sub-Saharan Africa alone, we have been able to reach over 90% of all the countries, all the 47 member states there in terms of their either self-assessment or a formal assessment. And we have 5 altogether, including Egypt in this case, that are actually maturity level 3 for vaccines regulation, together with South Africa. The other 3, Nigeria, Ghana and Tanzania, actually ML3 for medicines, but also for imported vaccines. So a lot of progress in the last 5 years, and of course, these countries are also contributing to almost 30% of the global population in terms of having mature regulatory capacities.
So you're trying to, yes, sorry, carry on. I was going to say
Yes.
building capacity, but of course, you also have this concept, don't you, of regulatory reliance, which
Yes.
is really interesting in that you are getting these national regulators to share data and evidence to speed up the process to get these products to the people.
Yeah, thank you. So just to follow up on that, the objectives of the regulatory system strengthening program of WHO has 2 components. One is the individual capacity building at the individual countries, but also secondly, to promote regulatory convergence, harmonization, work sharing, and reliance. So that has been part and parcel of the regulatory strengthening activities. We have promoted this work across the globe, but of course, we have examples in Southeast Asia where we have a regional network of regulators that are working together. In Africa, we have the famous AMRH, that is the foundation for the African Medicines Agency, and we are closely working with the EU organs to actually operationalize the African Medicines Agency as a stable and well-functioning agency for the African continent. I just wanted to, before I elaborate on reliance, also to say that the work we do to support countries, we're not working alone. We're working with our member states, but also with our partners through a new concept that was also launched 2 years ago, 2021, which is a coalition of interested parties. These are partners that are interested in regulatory system strengthening activities, both at the global level, at the regional level, but also at the specific country level, in order to avoid duplication of efforts, but also proper use of limited resources. As we speak, we have 21 entities that have actually met all the requirements to be a partner to WHO to support countries, but also regional networks. And we know that also IFPMA is one of the observers to this, one of the 4 observers out of the out of the 4 observers. We have altogether 17 participants that are actually working with WHO to support countries. To close on reliance, I must say that we have been, I think, doing a lot of work in this area, and COVID is actually a good example. Some of you may recall that when we had the very first few emergency use listings of COVID vaccines, we were able to see 101 countries actually granting regulatory authorizations based on reliance to the work done by WHO. So this was done within the first 15 days. And of course, as we progress over the years, we, at least as of end of last year, we have over 5,000 authorizations of individual vaccines for COVID that are coming from different manufacturing sites to more than 160 member states that have actually granted approvals based on the work that is done by the WHO through the emergency use listing or emergency use authorization by what we call today stringent regulatory authorities. And this work continues to the new initiative, which is what we call the WHO Listed Authorities Initiative, which is the new concept to replace what we all know as SRIs, or stringent regulatory authorities. With the concept in 2019, we published policy in 2021, and we have run some pilots, and as we speak now, majority of the founding stringent regulatory authorities are actually on the pathway towards performance evaluation and for them to be listed as WHO listed authorities with the launch of this concept last year. Finally, I just wanted...
Okay, good, because I'm wanting to bring in Caroline, and I'm wanting to go to questions from the audience. I think we've got a long list of achievements there, Hiti. One last sentence.
Okay, I think one last sentence is to say that we are also promoting a number of pathways. We have collaborative registration procedure for pre-qualified products, but also for SRIs authorized products. We have the EU Medicines for All initiative, or Article 58. We have got several regional joint assessments across our regional economic communities and also across the WHO regions that are all aiming to facilitate quicker access of products to patients. Thank you.
All about quicker access to patients. Just coming back, Leanne, I mean, this regulatory reliance idea that, you know, as Hiti said, was working during COVID, is that a win-win for you as well, for the pharma industry?
I would think so, yeah. I mean, I think that was a lesson from the pandemic as well, right? Where we could recognize and help really expedite. So I think that's the underlying intention here, and I think we're all encouraged by it. So looking forward to getting it in place and being able to get medicines to patients.
Yeah. It is all about getting medicines to patients. And Caroline, you're the CEO of AMREF. You also partner with communities in 35 countries in Africa. Now, the communities are the last mile, but in fact, they're the most important people here. So what do you think needs to be done to make sure that they're really first and center?
I think that is it's a big question. It's an important question. And this panel today is talking about UHC. When you talk about UHC, we're talking about health for all. And when you talk about all, it includes those people who currently cannot afford healthcare. So it includes all of these people. And it's really a question of equity. And the inequity that we see in the world as far as access to health is concerned, it is about the choices that we make. Choices as finance, choices as industry, choices as regulator, choices as community, as politicians, as national governments. It is about the choices that we make. So it means we need to ask ourselves, are we making the right choice? That's number one. When we talk about innovations to advance UHC, innovations are about solving problems. What problems do we want to solve? For whom? what will it take to solve those problems? And that innovation presents an opportunity for all the stakeholders to advance UHC. So for example, we've talked about diabetes. In a particular country in Africa, one of the access programs are around how do we get insulin to patients. And if you look at that program, if you understand the way the health system in many of these countries work, is for these medicines to be available in health facilities, they need to be part of the essential medicine list. So if you make sure that insulin is included in the essential medicine list, it'll be a priority purchase for governments, and then it will be able to get to the last mile through the public health system. So if you look at insulin, in this country, insulin is an essential medicine. The government procures it. It is part of the medicines that are covered by the insurance cover, the social insurance cover, which means that access for patients is eased. But the one-time use syringe, which is required, is not in the essential medicine list. So you've only solved half of the problem. In fact, you haven't solved the problem at all, which means that you have insulin, but you don't have the injectable that you need to provide the insulin to the patient. So an understanding of the context, of the problem, of the process, of the policy, of the regulation is critical. And working with all these stakeholders to make sure when you are solving a problem, you are indeed solving a problem for all, and that is how we would get towards advancing UHC.
Caroline, from that instance that you've just given us, it would seem that there's not always that joined up thinking, and there's not always that collaboration. I mean, you've got people from enablers here, from finance, from the industry, from the regulatory authorities. What more would you like them to do to make sure that they really do ask those questions that you've just outlined?
I think it's really, it's a cliche. But it's a cliche because it is indeed the right answer. It's about putting people at the center and designing solutions with people for the people who are going to use that solution. So if regulation only looks at the problem from a regulation point of view, if community only looks at the problem from a community point of view, industry, finance, then we each are just solving one very small piece of the problem. But if we try to understand what is the entirety of this problem, instead of looking at innovation as a means, but as an end. Yeah, you're looking at, I'm just not looking at having an innovation that is available to the market. I am looking at solving a particular problem. And therefore the metric that you measure is, have I solved the problem? Mm-hmm. And if you have not solved the problem, it doesn't matter that you've innovated.
Would anybody on the panel like to pick up on this very important role of end-to-end planning, and have you really solved the problem? Then, please, Leanne. And then he.
I would just echo. I think for our company, and I'm sure this is true for all pharma manufacturers, the patient is at the center from the origin, from what's that unmet need? What is that patient's journey going to be? How are they going to be able to access these medicines? That's at the heart of what we do, even before we think about taking that to the marketplace. So I think it's right to challenge us to carry it all the way through that process, and I'd argue that was, both our companies, and I don't speak, she's got the expertise here, but we've tried to take it to that next level and think creatively and innovate those solutions to take it to the local level, partner with locals to see if we can't get through that process. And then, as we've said, we need a multi-sectoral community, public and private, to come together, really committed to this. And I think with these kind of numbers that we're all reciting, it's pretty staggering that we could go on and continue to ignore it. So I think we stand partnered on the need to have a holistic approach to getting these medicines to patients.
Hiti, you've picked up your microphone.
Yes, I think she said very well, but just to add to say that, at least speaking from the regulators, what we know is that most of the regulatory entities, they are part of the ministries, they are part of the broader healthcare service delivery at the country level, and therefore those challenges are real, and in that case, then of course the best way this should be, there should be a consultation across the healthcare system at the country level, involving all the stakeholders, and to pick up what are the challenges and how this can be addressed together.
And you have to get the sort of patient groups on the boards.
Yes, yeah.
And
That
so
will
that
help.
their voice is heard.
Indeed.
Absolutely. Thank you. I'm very aware of time, and I'm very aware there's most probably some very informed questions from the audience to our speakers. So if you would like to ask a question, a mic will go round. Please raise your hand, say who you are and who you would like to answer your question. I would like to give preference to questions rather than comments at the moment, because we've got a lot of speakers, and there's a lady in front of me. It's always good to sit right in front of me, because if you sit at the back, the lighting is not so good here, is it? So there's a lady here, and then there's a gentleman over, sorry, you've already got the mic. You see, you can see. I cannot see because of the lights. I'm most probably sitting in the worst place. So the gentleman is standing, and then we'll go to this lady, if that's okay for you.
Yep.
Yes, thank
you so much. Excellent panel. Ed Kelly. I'm a former director at WHO, and I was director for service delivery. And probably my question is for Anne and Leanne and Caroline, but as former WHO, I want you to answer first, of course. But the question is really, I know we're talking about pandemics next, but COVID, the lesson from COVID was not that there wasn't enough investment in upstream R&D innovation. It was really about, we didn't invest almost anything on the delivery side of that. And I just wonder, specifically from an industry standpoint, what your thoughts are on how to better look at innovations in delivering vaccines and drugs, both programmatically and device-wise.
Okay. Yes, GSK, Eli Lilly, would you like to take the question about the delivery? We know that it was all about, wasn't it, getting the vaccines, but we had the vaccinations, but did we get them in? We had the vaccines, but did we get the vaccinations into the arms? Yes, what can be done to improve delivery?
Yeah, well, I think indeed it has been a very clear example with COVID that all of a sudden when vaccines were finally there, that clearly implementation was still a big challenge. And I think we see that not only for COVID, but in general, there's other areas, for instance, in respiratory, where GSK has lots of products available, but where even many generic products are largely available. And it doesn't mean that even products are available. They may even be very affordable. But if people do not have access to a healthcare system where there is not a diagnostic tool or no awareness about the disease, when then there is no proper treatment provided because maybe treatment guidelines are not up to speed or there has not been sufficient training, then still, well, you don't see the impact. So I think it's really, again, probably bringing it back to what we concluded on the panel discussion, is that for all those areas to work, this multi-sectoral collaboration end-to-end, to really start from when you develop this innovation, how will it reach the patient, and from that perspective, what is needed to make it work, and then start on everything in parallel, work on the policy, work on the training, in order to make sure that at some point in time, all those things come together at the right moment. So it is a very big endeavor. There's no simple solution, but it's such a holistic approach that in every single disease area is needed in order to really improve access and health coverage.
Let me just add on to that, because that's amen to what you just said. But at Eli Lilly, we had a monoclonal antibody, and we were one of the first to have a solution out there for some patients. But it was some challenges for all the reasons you said, as well as still within the regulatory arena. So we in the United States, there was a mechanism to try to to accelerate approval. In order to get it to the U.S. population. But when we were working even in developed countries, we found that we just didn't have approvals. So the drug, we were willing to, it met our criteria, we were willing, and we had tiered, like a lot of the vaccine companies and others had done as well, tiered how we were going to charge. So we basically had the philosophy wealthy countries should pay for the antibody, at least that we were doing, and found that we were often stymied because the local regulators hadn't approved it. And so I'm not jumping on you. I'm just saying I think that was a process that we need to mature and bring along as well, because it wasn't ready to respond as quickly in many markets.
And the importance of building capacity, just as Hiti was outlining. Thank you. Farid, if you'd like to say something, and then I'm going to go to this lady.
No,
here.
just quickly on this point, because this is an important point, and it cuts into the intersection between what you two do, which is really bringing the drugs and the products and devices to the market and distribute them. But you need somebody to deliver the services to the patient. You typically don't do that. So it's important to put into the equation who are the healthcare services providers, whether hospital, diagnostic centers, primary care clinic will come on the next stage, I think, of the questions. But this is key to combine the ecosystem and work on all of those sides, including the regulatory on delivery and production. But if you don't really strengthen that piece of service delivery, the last mile including, then I don't think you reach the patient. So it's
yeah, absolutely. If I could take a question from this lady, if you can say your name and who you would like to answer your question.
Thank you. Elaine Fletcher from Health Policy Watch. To Dr. Silo. It's clear that WHO has been playing an increasingly important role in the regulatory space, but I just wondered if you could spell it out a little more, because pre-qualification is a pretty old term that I think began with the qualification of manufacturing processes, but now has moved on to really approving products. And that's so important to low and middle income countries that may not have their own strong national regulatory system. And then if you could just say a few words about the SRI, because that seems to be yet another step forward that I don't think I've heard explained much, and I think is also very relevant. Thank you.
So for SRI, you'll have to explain to me, and
Well,
perhaps not to the audience.
That's why I was.
But yes, you have maximum 3 minutes, Hiti.
Thank you. Yeah, just also to mention here that my director is sitting in front of me, so he is responsible for my unit, but also for pre-qualification, so he can address part of that when he comes on board. So, what I can say is that the scope of pre-qualification is also limited to a category of medical products that PQ is currently supporting countries in terms of assessing those products, inspecting the manufacturers for compliance to the latest requirements on good manufacturing practice. And this will inform the global procurement mechanism, Global Fund, UNICEF for vaccines, and of course others. So PQ is still needed by countries, if you ask us, and it's very much needed by many of the low and middle income countries in terms of the work products that, the products that get pre-qualified, but also during the emergencies that get listed. Countries can rely on PQ and take quicker decisions to get products to the market. So this is what I can say. And of course, the scope of pre-qualification is also goes beyond products. You know, it also goes to quality control laboratories that are used for testing of products, especially pharmaceuticals. So we have a program for assessing, first of all, for assessing to identify gaps, but also supporting labs, and then when they are ready, they will be inspected for pre-qualification. And this has been one of the greatest services to member states from our pre-qualification program. But Rogero may want to add on that. Secondly, to clarify on I think you meant SRIs. So SRIs stands for Stringent Regulatory Authorities. It is the term that was introduced many years ago to very pragmatic approach to facilitate and guide global procurement decisions, and especially the Global Fund and of course other UN agencies. And this term was limited to the members the member states to the International Council on Harmonization, and here we are referring to the EU, US, and Japan, but of course Australia, Canada, Switzerland as observers to this, and I'm sure IFPMA can speak for this more than myself because they are also a key partner to this. And as of 2015, and following a lot of discussions among regulators on the need to also recognize other regulators that are actually investing in regulatory systems strengthening that can also be classified as or categorized as stringent. So there was no way they could be recognized unless they are coming from these geographical locations. And therefore, The decision was to actually open up this. Of course, ISH also itself went into transformation and reforms, and also opening up to other member states to join, to become ISH members. So the only way to also recognize other regulators that are as good as this was to come up with a new concept, and the decision was made by our expert committee then that on specifications for pharmaceutical preparations, that we need to move away from this concept and come with a new concept that is more transparent, that is also providing evidence against which a country, a national authority is actually listed and also globally recognized. So we started the process of coming up with a concept note, as I said, and then with a policy to change and also to provide a pathway for evaluating all the regulators so that they can be recognized at the global level as stringent or mature agencies. So this concept was launched last year. As we speak, we have 57 NRIs that are actually on the transitional list, including the founding members the founding ICH, the founding members of the founding member countries that were members to ICH. So they are all on that, and as we speak, we have done 3 pilots in 3 countries. We have received expressions of interest from majority of the founding SRIs, and we hope that in the next 1 to 2 years, Rogero will say by end of next year, we should have all the SRIs on the on the WHO listed authorities. Thank you.
So, thank you very much for those questions. I am trying to allow some time for questions, but I would like to thank our first panel of innovators and enablers from the World Bank, from GSK, from Eli Lilly, from WHO, and from AMREF. So, a round of applause, please. And we've already had a question about pandemic preparedness, but that's where we're going next. So if I would like to encourage everybody eloquently and elegantly, and we don't see the scene change as these people leave the stage. And I would now like to ask our speakers from the next panel to come on stage for us. Thank you very much, Anamaria. Of Gavi, Helen, welcome, Helwan, and we have Thomas, of course, and Rogero, who's been trailed ahead by Hiti. Thank you. So, yeah, pandemic preparedness, as you know, is a big focus of this year's World Health Assembly. And in a moment, we're going to be hearing about the 100 Days mission to respond to future pandemic threats and how regulators and the industry are going to support that mission. But first, I'm going to make the link between universal health coverage and pandemic preparedness, and I'm joined here by Anamaria Bejar, Director of Public Policy Engagement at Gavi. So just explain very briefly, strengthening of health systems, why is it so important for pandemic preparedness?
First of all, thank you for the question and thank you for the invitation, IFPMA. Really, I think we all have lived the pandemic and have this nervousness about, how it's going to impact my family, my friends. And that very much depended on how your health system was strong or not to respond. And that is something that you said in the previous panel that needs to be done between pandemics. My organization is a public-private partnership. Sorry, it's always the 3 Ps that you have blocked me. And our mission is to provide immunization to people and access to health. And within that strengthening of health systems, routine immunization is really something crucial. Why is that? It's because routine immunization is one of these interventions that really brings the health service to the communities at least 4 or 5 times per year to reach children. And pandemics are less able to succeed in damaging human beings if they find people with better health. But also, immunization is a platform to strengthen health systems. When you have a stronger immunization response, immunization system in a country, you have better data information systems probably, you have better surveillance, better trust between the health providers and the communities, which is something that we know that was an issue during the pandemic, and more opportunities to provide other health services and provide access to universal health coverage. In the same visit that a mom brings his kid, that can be a consultation about issues that she is going through, like, for instance, contraception or many other things, no? And so we do think that
routine
immunization is key to improve primary health care and strengthen health systems and also achieve universal health coverage.
Absolutely key, as you've said, but I suppose it's in the name, routine immunization programs, and there was a big setback, wasn't there, during COVID in these. So how much catching up is there to do?
It's a huge catch-up that we need to do. We all know that most services were affected by the pandemic. Within that, routine health services in general, but also routine immunization. Unfortunately, 48 million children did not receive any vaccine whatsoever between 2019 and 2022. I just want everybody to imagine that number. To imagine the populations in the countries you live and you are related to, and it's 48 million children. And that is in 4 years. We have kids of 4 years old completely unprotected. And that's why we have seen, for instance, outbreaks in polio, in measles, in diphtheria, in yellow fever. So the catch-up is enormous, and that's a task that we have together, I think, as a community, not only of health, people interested in health, but also people who cares for development and for equity, and for bringing exactly, what universal health coverage means, that is bringing health access to people everywhere, when and where they need it, without facing financial hardship.
So thank you. A lot to do to catch up. One of we all know the negative impacts of COVID. You mentioned the lack of service delivery and getting some of those products to the people, but also COVID also meant, as you said, those 48 million children, the no-dose children during the pandemic. So the pandemic is over. But of course, we want to better prepare for the future. So let me introduce Helwyn Philpott, who's the head of the International Pandemic Preparedness Secretariat, Rogero Gaspar, Director of Regulation and Pre-Qualification Department at the Access to Medicines and Health Products Division of WHO, most probably somebody who doesn't need any introduction, but I'll do it anyway, Thomas Cueni, who's the Director General of IFPMA. And I'm going to focus the first part of this discussion really on something that Helwyn at this Pandemic Preparedness Secretariat is rolling out, this 100-day mission to better respond to future pandemic threats. I mean, what is the mission and why 100 days?
Thank you. So many think this is a slightly crazy mission, and in many ways it is. But as we know, the first 100 days are absolutely critical for changing the latter course of a pandemic. It was incredible that the collaboration and innovation that we saw develop vaccines, therapeutics, and diagnostics within 326 days. But when you look at the graph of the lives lost and the increasing cases, how different would history have looked if we'd had those products within 100 days, if we could have bent the curve, if we could have avoided trillions of dollars of economic loss. And so this was a mission conceptualized in 2021 between CEPI and G7 and WHO and lots of great thinkers of what would it actually take to be ready to produce vaccines, therapeutics, and diagnostics that were both safe, critically, you can't rush that, and effective within 100 days. And so the 100-day mission came up with a set of recommendations to develop what it would look like to have a global system that was ready to do just that, to have vaccines, therapeutics, and diagnostics within 100 days.
And Helwyn, I was just wondering what progress have you made? We'll look at some of these. We won't look at all 25 recommendations, but we will look at some of them. I'm just wondering what progress have you made since that G7 meeting?
Yeah, so that was 2021.
Yeah.
And since then, we've been focusing activities in 3 main buckets. The first is to try and fill the gaps in R&D in our arsenal. We now know what the top 10 pathogens of pandemic potential are. The R&D blueprint are currently updating that list. And what we want to do is develop effectively a scorecard working with WHO to look across those pathogens, work out where we have vaccines, therapeutics, and diagnostics in the pipeline, where we know funding is incoming, where public and private funders are putting funding into those particular pathogens, and then map the black spots where no one is currently investing, where there's very few candidates in the pipeline, and then have a very frank conversation about incentivization and how can we incentivize investment in some of those products where no one else is going at the moment. So that's the first thing, filling gaps in the R&D arsenal that we have. Second is about making the exceptional routine. As I said, we saw a lot of exceptional innovation, a lot of exceptional collaboration that we've heard about on the previous panel as well during COVID. And it's thinking about which are the elements of that exceptional collaboration that we can make routine. And excited to hear what Rogerio is saying about regulatory innovations, because that's definitely one area where there was some really exceptional collaboration, and thinking about where are the processes we can parallelize in day-to-day innovation to support UHC? Where can we have learnings from the clinical trial platforms and infrastructure that was set up that can be a standing capacity that can support UHC and keep us ready for pandemic preparedness? And then the third bucket is agreeing the rules of the road now for a future pandemic, so that we don't spend time on day one of a future pandemic negotiating where the surge financing is going to come from, that we already have processes in place and know the levers to draw down on that. That's a whole bigger conversation, and that's a lot of the things that are being negotiated through the IMB. But those are the 3 buckets: filling the gaps in the R&D arsenal, making the exceptional routine, and agreeing the rules of the road. And I would say the main area we're seeing progress is the collaboration and the ownership that organizations are taking. The 100-day mission cannot be achieved by any one sector or any one organization. And we're trying to develop a framework for ownership and delivery, setting really clear milestones. And we're seeing some really exciting people come in behind that. Steppy is doing incredible work. Find is doing amazing things on diagnostics with a 100-day diagnostics roadmap. The Intrepid Alliance is a group of companies doing pre-competitive collaboration to try and have 25 phase 2 ready antivirals by 2026. There's lots of exciting examples of that, and I'm sure we'll get into it.
And I was going to say, I'm sure Thomas most probably would want to talk about how the industry is really supporting that mission. You mentioned the Intrepid Alliance. Perhaps, Thomas, a few words from you about this mission. Does it sound crazy to you, as Helwyn has just said? And how are you going to support this crazy mission?
I don't think it sounds crazy. It sounds ambitious. That's why sounding ambitious does not mean that we should not strive to meet it. I'm actually surprised that there are people who are questioning, the relevance and importance of a 100-day mission. How can you be against it? Because we were lucky in the COVID-19 because 326 days was pretty amazing. And I think quite often unsung heroes of making it possible are not only the researchers in companies or academics helping, and engineers, scaling up, but also the regulatory agencies. I've never heard so much praise for regulatory agencies as during the early phases of COVID, because you had the IFPMA,
and Rogerio will tell us about some of those, and he'll also some of the successes.
Also, since somebody actually left me stranded, I had the pleasure of having a 45-minute chat with Rogerio before this whole thing started. And I must say, when you look at vaccines, WHO has really done an amazing job in granting emergency use license for the first vaccine within weeks, literally, of MHRA having approved it and the FDA having approved it. And within 6 weeks later, the first shipments did arrive in Africa, in Accra and Ghana and other countries. Now, from an industry point of view, as I said, aim should be to be faster next time. In order to be faster, I think we need to join forces. That's why I'm really pleased, as we have been pretty much involved relatively early on from the private sector. I have the pleasure to being on the steering group of the independent secretariat, because they understand that at the end of the day, the likelihood that the next tests, vaccines, and treatments again come from private companies is rather high. No disrespect to FIND or WHO or CEPI or Gavi. Their mission is not really developing and scaling up, and they need the private sector. And that's why it's important, and I do believe that we from the private sector need to be involved in what Holman said, you know, doing more prep work on priority pathogens, trying to develop prototype vaccines. We benefited with SARS-CoV-2 from knowledge known about respiratory disease. mRNA were a game changer, but I think we need to be cautious not to focus all our energy on one single platform. We need to have others. The next pandemic may not be actually as easy in terms of coming up with something in 100 days or even in 326 days. Therefore, we need, I think, personally from the industry, I see we have a move towards more open innovation on pan-prep. We have a move towards more sharing in pre-competitive research. And we clearly saw from the beginning of this pandemic a willingness among companies to share and reach out, whether it was the Lilly's or the Pfizer's or the Moderna's. We really, you know, the partnerships we saw were amazing. Second element, I think we need not only to make the exception the new norm, I think we need more regulatory innovation. And I've heard a speech by one of the leading US regulators saying, and probably we could do much better on, for example, GMP, good manufacturing practice, where we can't compromise on quality, but there are probably bureaucratic elements in, you know, variant changes, in formulation changes, where without compromising quality, you could be even faster. And we also need to work on, can we get sustainable life cycle immunization? Is it really feasible? You will never have ever warm vaccine plants if they're not warm, which means if the sustainability is not there, we will again be, you know, confronted with what WHO basically knows. We had the network of flu plants created some almost 20 years ago. Literally none of them still is in existence. Therefore, I think we really need to join forces, understand that private sector is important, innovation system is important, access to pathogens remains important, but we need to work in collaboration. And that's why I must say, what I encountered during the pandemic, for example, in COVAX, this team spirit I saw between everybody who was involved, from Gavi, from UNICEF, from CEPI, with WHO, trying with the private sector, also from developing countries. I've never encountered that. If we make this even better, I think then the 100-day, you know, we got the man on the moon. We haven't succeeded in the fight against cancer yet. Therefore, aspirational is not guarantee for success, but we need to be trying. And full support.
Yeah, you were mentioning, of course, we don't know what the next pandemic will be. Vaccines were quite successful in dealing with COVID. But just a couple of words, Thomas, because you've got this intrepid alliance that Helwyn mentioned. And this is accelerating development of new treatments, isn't it? Because perhaps we didn't make so much headway with treatments last time round.
You know, one of the lessons learned in the research area, and Holman already alluded to it, there were some neglected infectious disease areas. Antiviral research has, you know, some companies were always keeping in, and we benefited in that respect in terms of the small molecule antivirals, and we benefited from companies' willingness to open their libraries and to look into repurposing. But there has been a bit of neglect in antiviral research. And that's why, on the one hand, you have companies pursuing what they always did, and you have quite a number of companies who joined forces with this intrepid alliance And it's obvious they're interested in sitting down with the 100-day mission. They're interested in sitting down with the Patrick Valences, Hoylman, and others. And I've seen a lot of interest from heads of research, for example, to become a member of what's called the STAG. And I'm sure you have never heard about STAG.
And that sounds like a European Commission scientific task force.
It's basically the scientific advisors.
Yes, absolutely.
With my usual diplomatic restraint, when we talked about the need to bring in CSO and others, I said, you know, that's like asking me to sit on the STAG. I'm not a scientist. And therefore, there are some matters which should be left to experts, like Rogerio, or like, you know, the scientists, academic or others. And there's a willingness among the best leaders of R&D from small and big companies to contribute collectively to reflection. Where do we really need to do more together?
As Helwin was saying, the gaps. Well, Ruggiero, you've been given a big build-up by people on the last panel and on this panel. And indeed, there were some successes, weren't there, from a regulatory perspective during COVID. If you could briefly remind us what they were, but I mean, how do we make sure that we build on those and that they're maintained in normal times and that they're there for the next pandemic?
Yeah, thank you so much. Let me say that this kind of conversation 4 years ago was probably impossible. And the first thing that we need is to recognize what changed. And the pressure to change was not coming from inside of the institutions, IFPMA, WHO, regulators, was coming from the simple need to work together to answer to a dramatic situation. That dramatic situation, we have accounted directly on the official number, 7 million dead, probably close to 20 million, as the Director General referred at the close of the FAKE. And on the 7 million, which are the official count, let's also reflect, and the numbers are not from WHO, are from a group of scientists from Oxford University, published last October in Nature. Probably 1 million are responsibility of vaccine hoarding. Just to remember the pain that was inflicted unnecessarily because of lack of coordination in order to follow what was the indication from WHO from the first moment that we needed to focus on around 20% of the population in each country, looking at healthcare providers, looking at older population, looking at comorbidity. So there's a number of very hard lessons learned from this crisis, and I think that everybody that is working in this field understands that there are a number of successes, but a huge amount of work that need to be done. And to understand that the fact that we had an emergency use listing, that we had something that was ready to go, was the consequence not of COVID-19, but from the Ebola crisis in 2014, 2017. So the response to the next one will be the consequence of the lessons learned during COVID-19 and what we are able to do with that. So let me start by that, because sometimes we tend to get too much on the celebration part, and I think there's a lot to celebrate, but a lot of concerns also to move ahead in terms of the changes. The second point is on the 100 days, and I told you during the prep, and I can share in the meeting, I'm co-chairing the regulatory advisory group with Adam Hacker from CEPI. So when the G7 in Cornwall is at that first report, and CEPI was collaborating in that, my first reaction, and Adam will not be mad at me to share this in public, was, what have you done? Because once you fix a number in the political arena, to move it out, then it's a nightmare. But being one of the skeptic ones in the room from that first day, I have to tell you that I was convinced that let's not fix in the round number, 100 days, but on the dynamics around it. And to give you an idea, if we design a single-arm immunobridging study right now, we probably can do it in 30 days. If we look at Sudan Ebola, and what WHO did with universities in Uganda and Uganda Health System, we're ready to go for a clinical trial on vaccines that were never tried on Sudan Ebola in less than 70 days. We have today manufacturing capacity with other technologies with a very short time for roundup between changing the composition of a vaccine to another composition of the vaccine. And we saw this last year after the decision of the TAC-COVAX from WHO and introducing the bivalent vaccines with Omicron strain included. We'll probably see this year again after the statement a couple of days ago from the TAC-COVAX on the new composition of vaccines for the coming future. So if you don't fix on the 100 days, but we fix really on how we can compress the timelines, also for reference to understand that rolling review seems like a revolution that occurred during COVID-19. And it is a revolution, the fact that it occurred during COVID-19. But let's be frank about it. The first papers where we have the theoretical design for that system are from 2007, published by PwC on a document called Pharma 2020. It took us 13 years and a pandemic to move from paper to practice.
So is that something that you can then now apply in the future?
I think that now we've learned that we don't need another 13 years to move from paper or from the design board to practice, and I think this is one of the major lessons. How we did that? One of the questions that probably is not a big secret, a lot of people in the room know the mechanic, but we tend not to integrate that in our conceptual view. How do we manage this integration between manufacturers, health systems, regulators during this crisis? A lot of investment from the public sector on the private sector, Warp Speed in the US, other programs in the European Union. Not all successful. We still remember a major project on the European Union on an mRNA vaccine that was not successful, and we have also to be humble and to recognize it's not only about public money or private money or putting money, it's about a conceptual design and strategy that needs to be there. But WHO organized from the beginning under the leadership of Sumi Swaminathan, but also Anamaria Restrepo and others on the R&D blueprint, a number of consultations with the scientific sector that, of course, you don't discuss too much online when you have 24,000 people or 1,500 people, which are the two limits of participation of those meetings. But when you have 3-4 meetings like this per week in the initial phase, or meetings like that every week or every month on a later phase, the level of understanding from the scientific community about the problems, the issues, and how to solve them doesn't have any comparability in historical terms in terms of reaction to that specific problem. We had also COVAX with the Regulatory Advisory Group, Chatham House rules, Thomas Cueni, and discussing every month 15 major regulators, WHO, CEPI, with manufacturers about how to solve the problem here and the problem there. I can tell you that immunobridging took us to move from a conceptual phase 3 clinical trial to an immunobridging. It was roughly close to 1 year of scientific discussions and regulatory discussions. Not an easy path, but we were able to find a common ground under a certain number of rules that allowed for the third component to come in, which was IFPMA, the International Coalition of Medicines Regulatory Authorities, and the consensus that was built there.
So, Ruggiero, we saw that there was the rolling reviews, we saw there was great harmonization of regulators, but, this time round, what do you think needs to be done better? Can you keep everything that was good, and what do you want to do better?
Honestly, I think that the main danger that we have currently on the table is that people tend to forget very rapidly the lessons learned in this crisis. And I think that my main concern today is that the lessons are not forgotten, and that we don't try to forget what happened in the last 3 years and trying to go back to 2019. We cannot go back to 2019. We learn a lot how to improve the regulatory system. Just to correct some numbers that I heard on the previous panel, there was no regulatory barriers for national regulatory approval. We did 5,400 national regulatory approvals in 160 countries in 18 months. We really did the first 2 vaccines for the COVAX facility in 2 weeks, not in 6 weeks. In 2 weeks, we had approval in 101 countries. And even without quoting specific member states, having a major member state that was probably the principal provider of donations for the COVAX, with some legal issues because they cannot share governmental documents with foreign countries according to their law. Even in that limit, I have to say that the National Regulatory Authority, and probably I need to disclose it, FDA, almost crossed the line between infringing federal law or not, providing solutions to share documents that in normal time they cannot share outside of the US federal government. Redacted inspection reports for GMPs that were unredacted to allow for countries to do national regulatory approvals and to receive donations from COVAX. So the level of trust and working together between regulators doesn't have any comparability in history, and believe me, Thomas knows that, 3 decades of this job, and I've never seen this. So let's not
Let's not forget the successes. Yeah. I'm wanting to take questions from the audience.
Can I just go for
quickly,
one? Because
yes, because I do want to bring
Thomas
back Helwin.
And others referring GMPs and regulatory innovations. ICMA as a group, there was a document, internal document on ICMA about regulatory agilities. The 2 rapporteurs for that document are WHO and Health Canada. And there's now a working group led by the European Medicines Agency on that. The discussion again about facilitating GMPs and even remote GMPs with no technologies was firstly discussed at ICH 6 in Osaka 2003. So again, this is about, sometimes we need some dramatic events to move us from point 1 to point 2 because everything is already there. We know exactly what needs to be done, but that jump, both from the industry side, from the regulatory side, from the health system side, sometimes need some dramatic events to move. And let's take this opportunity to not move back on what we have achieved during this crisis.
Thank you. Helwin, just coming back to you, you had your the filling the gaps in the R&D blueprint, and we heard from Thomas, and making the exceptional the norm, as we heard from Ruggiero, and what the regulators were able to do. Your third bucket was about the agenda, the road, the rules of the road. Yes, a few words on that, perhaps.
Sure. So the rules of the road, as I said, is about negotiating before a pandemic starts the rules of the road you want to operate on. And there have already been some really great lessons learned from ICMA on the pandemic rules of the road and regulation that they want to do differently. And I think we just need to make sure, as Ruggiero says, that all these lessons learned in this document don't just gather dust on the shelf, that we actually see regulators, governments, organizations implementing them as business as usual. They become part of the way that we work, that we learn these lessons now before it's too late, before people change jobs, before political will moves on, as we're already seeing. The other part of rules of the road that's really critical to get right, that is critical to the access point, is surge financing. And there's some really great work being done at the moment by the G20 Joint Finance and Health Task Force that's looking at this, and Gavi's doing really interesting work that's critical to what you do. But that's still the piece of the puzzle that feels like we haven't quite fixed yet. There's lots of things where we've learned the lessons, and it's about implementation. I think surge financing is a bit where we don't quite have the right solution yet. There's lots of different financing mechanisms out there, and this is not my area of expertise, but it was clear that there was a gap on day 0 to allow LMICs to get in the procurement queue at exactly the same time as high-income countries. And depending on what scenario we find ourselves in the next pandemic, you may need different surge financing mechanisms. If you've already got products, it's about manufacturing scale-up and funding that, and procurement of those. But it may be that actually we don't have a product, and it's about investing in accelerated R&D. So in my mind, that feels like one of the big pieces of the puzzle that needs to be fixed. But there are smart people that are looking into it. I know that Italy in their G7 next year is excited about taking this forward. Brazil as well, and I think it's one that we need to keep plugging away at and put our best brains on, and really interested in any ideas the audience has.
Absolutely. And I mean, you mentioned equitable access. We remember one of the downsides of COVID was all of that vaccine nationalism and hoarding. Thomas, a few words, because you came up with this Berlin Declaration, didn't you, which was really a way of supporting equitable access and making sure that that didn't happen again.
I think it's obvious when you look at the experience in COVID, rollout was not fast enough around the world for a number of very specific reasons. I personally believe we need to act on 2 fronts. The first one is the likelihood that you will have some parts of the world coming up faster with vaccines, with treatments, with tests than others is high in the next pandemic, which means you need a signing of a kind of social contract. From the industry side, we do have a commitment from CEOs from all the major companies, endorsed also now by bio, the small biotech companies, and let's face it, Moderna and BioNTech were not part of IFPMA, and also by developing country vaccine manufacturers, committing to putting aside part of available production in real time for rollout to the vulnerable wherever they are. And that, I think, is absolutely crucial, because that's probably the most pragmatic, game-changing change which we can bring about in the next pandemic. Will only work if the manufacturing countries, to mention just two, US and India, will also sign up to that commitment. Because if they say, oh yes, you can have access to whatever we have after we vaccinated every single of our citizens, this social contract is broken. And as Switzerland is not part of the European Union, but I must say the European Union never had an export ban. Never had an export ban. There's some excruciating bureaucracy in terms of export permits, but they never had a ban, with one minor exception. And I think that's what we need. And secondly, when you look at what happened in Africa in 21, from April 1, when Prime Minister Modi shut the border from India, and nothing was left Serum Institute, which was supposed to be the main supplier for Africa. For about 6 months, Africa was left without vaccines. Therefore, when you look at what happened there, and although I hope that the social contract will work, we need to work together on some geographic diversity of manufacturing. I had a dinner last night with somebody who said, actually, it's not bad if you pick hops from small countries. The likelihood that they will not allow exports is much less than when you have major countries. But we need to work and help, for example, in Africa. The one addition which I make, I believe the only way which promises success is voluntary, with maybe a little bit of arms twisting or incentives from governments. And we have seen that even in the US. And it is B2B. You need businesses trusting each other, working with each other, and there you can have collaboration with governments, you can have collaboration with regulatory agencies, because I really believe that's needed. And in terms of, I just, want to rephrase, full, kudos to the regulatory agencies. For example, when I read some of the books about, the vaccine development, and you had the Paul-Ehrlich Institute in Germany traditionally insisting, oh no, how dare you even think about foregoing toxicology studies? And at the end of the day, it was possible. It happened. And that's why I think it needed courage from regulators. It needed this, 24/7 year on it. That's why I really want to praise what was done. I have to admit, Rogerio and I have slight nuances in terms of the vaccine's performance versus the therapeutic performance, but that's probably a topic over drinks and beyond.
Okay, so let's hear from our audience if you have any questions about the 100-day mission, this ambitious mission, as we heard with the R&D blueprint and making the exceptional, which the regulators did during the pandemic. So if you have any questions, I'll take questions for 5 or so minutes. I'm going to look at the back just to make sure that I haven't missed anybody this time. And there is a lady with her hand. Well, there's somebody, yes, with your hand up, and I think there's someone behind you. Please, if you can say who you are and who your question is directed to.
Yeah, thank you for the floor. I'm Angela, and I'm here representing the International Pharmaceutical Students Federation. So this question might be for all the panelists, so it could be from anyone. In correlation to the third SDG goals, which is relating to the healthcare workforce, the empowerment of healthcare workforce, as youth, how can we take part or contribute to support the achievement of better pandemic preparedness, as we might be the next generation or the future human resources in the future healthcare workforce? And how can we also improve equity, health equity relating to the better pandemic preparedness? Thank you.
I think that's a question for Helen. Don't you? As
I'll
she's,
give
on
it
a,
my
on,
best
she's
shot.
on a mission. Yes, yes.
What a great question. The fact that you're asking that question gives me so much hope, so thank you. That's the best place to start. I think the main thing I would say is learning this lesson from the discussion here and on the previous panel, actually. It's these end-to-end systems and thinking in that end-to-end way with access by design from the very beginning. When you're thinking about target product profiles, making sure that's a conversation between companies and communities, as was highlighted by the GSK malaria vaccine example, starting by access by design at the beginning and carry that thread through at every single stage, thinking about how will this help these products have most impact at the end. And then it's about building the relationships that enable that end-to-end system to work. So become really flipping good at whatever your job is, but make sure you're best friends with the person that does the job either side of you in the supply chain. And building those networks. WHA is a great place to network, to make friends with people at different stages. I'm not a regulatory specialist, I'm a policy specialist, but I'm very glad that there's people in the world like my colleagues on the panel today, and I'm really invested in their success because I know that it's about the whole end-to-end chain. So I suppose that would be my answer. Think about access by design from the beginning at every stage, become very good at what you do, and think about end-to-end and knowing people either side of you.
Anamaria, you also wanted to pick up on the question about the role of young people.
Yes, thank you very much, Angela, for your question. It's truly important. What can I say? I think in terms of human resources for health, it's very important to recognize the social determinants of health. One of those is gender. We have 70% of the health workforce are women, and 92% of the frontline workers are women. Surprise. So we need to have gender policies that, first of all, enable their development to take leadership positions. It's only 25% of women who occupy a decision-making role in health. That's terrible, right? I hope that when you get to my age, I'm not gonna reveal my age, but when you get to my age, things change. So it's very much in your hands. And also, equal pay. We talk about equity, and equity is reaching the left behind, reaching the people who don't have any access, not just to health, but to any health, any service. Recognizing and really learning, right? Challenge us, challenge the people who are in this fora. And it would be great to hear what you think that could be better. There are, also in immunization, I told about the challenges of 48 million zero-dose children. They are not children living in isolation. They have families. They have context. They live in humanitarian context. They live in poverty. They live in rural areas where health cannot get. So thinking about them all the time is truly important. What else? Also learning from experience, I was saying that there are some countries who, despite the pandemic, have kept the same levels of immunization, like India, Pakistan. And DRC, for instance, introduced the rotavirus vaccine during the pandemic. So, there's possible when you have political will, good leaders who care about people and care about youth and women and everybody who is not, unfortunately, having the complete integration to society is very, very important. So thank you for your question.
Lots for young people to do. There was somebody behind you who had their hand up. If I was right to take that question, was that? It's very difficult, isn't it, with the lights?
Someone by the lights.
Oh, there's someone by the lights. Okay.
Hi. My name is Samantha Bolton, and I did some work for Médecins Sans Frontières on the COVAX vaccine. And we had a whole group of people looking into it, including the ICRC, because actually, even though, of course, everybody wants Africa to have access, the reality was that it didn't happen. And of course, the middle classes will get it through their direct contacts with their private doctors. But when it came to COVAX, virtually none of the big pharmaceuticals participated. It was basically China and a few others. And one of the main problems was the indemnity and liability. So just as the pharmaceuticals forced all the governments who took the vaccines in the West to take full liability for the vaccines, for any side effects, which, as we know, when you went and you said, for example, when I went to get vaccinated in Switzerland, I said, oh, by the way,
so
are you
Samantha, just before you, could you direct a question? It might be to Thomas.
So the question is, if you really want people to get the vaccines around the world, first of all, this liability thing where you hand it over to the UN and then they hand it to the NGOs, only MSF and ICRC really had the capacity to do anything, and none of us could do it because we were blocked. Because ultimately, a patient may sue MSF or ICRC, but they're not going to sue the WHO. It's too big and unwieldy, or UNICEF. And why is it that even though you talk about it here, Africa, in reality, none of you signed up to any of these COVAX or other facilities? Thank you.
Thomas, COVAX.
I'm not quite sure that this was a question. It was a statement. Basically, I think one of the major achievements of COVAX, which provided vaccines for 91 countries in the world, that while the crisis was already on us, COVAX managed to negotiate a framework agreement on indemnification liability, which covered the whole of the COVAX regime. The one on, unresolved issue is, how do you deal with the emergency situations, the refugee situation, where you have ICRC or others? That's something which we discussed, for example, in Johannesburg at the MCM, and everybody who was there agreed we need to sit down and look how we can resolve that, period.
So, Samantha, you know where Thomas is. He'll be in the networking cocktail and our other speakers. So please ask your questions there, because I am now keen to give the final word. Ruggiero, you wanted to say something, and then I'm going to go to Thomas for the final word, because we do have a launch of an Innovators Award that I would like to get to.
To address two issues. The first one was with the previous question, but I will go directly to this and then complete with the previous one. One thing that we need to recognize, and this was said by our Director General and others at the opening of the current World Health Assembly, is that during this crisis we had a problem with the humanitarian buffer. And I think everybody recognizes that, so we need also to be humble and to recognize where some failures existed and why they existed and why they shouldn't exist anymore on the next one. So there are a number of lessons learned. As I said, let's not celebrate only the victories, let's look at the problems where they were and trying to find the solutions for that. It's much more complex than it seems, but I think we have the responsibility to do that. The other part on the question from IPSF, I was smiling because 42 years ago I was in that position. As a member of the individual member of the European Subcommittee from IPSF, EPSA was not yet there. And Thomas knows one of my great friends that was also part of that, also Portuguese, Rui Ivo, and is currently the head of the Portuguese Regulatory Agency and leading the European Union Health Technologies Assessment. I'm here at WHO. So, the work that you can do from there is to get the competencies to be here one day and to move the agenda on the direction. And I think that APSF, I was today meeting with the FIP, and most of the people that were there around, some of them were my students, others were students from friends of mine, and they grew as part of a global community, a community of healthcare providers, not only at the health system, but also in health policy, building the agenda. So the responsibility is collective, and as health professionals or future health professionals, our responsibility is bigger than others.
Thank you. I'd like to give the final word to Thomas.
Thank you very much. And my final word would be short and succinct, because I'm now really the one standing between this and the drinks and the aperitif rich. I think I will not try to summarize what we heard. I think one clear message from everybody was the importance of partnership, the importance of openness, and also the importance to agree that we didn't do badly, but we can do better, and we need to be willing to learn the lessons from that, including, as Rogerio just said, address the difficult, complex issues like the humanitarian buffer. We also, I think, clearly need to work together on improving UHC, because when it comes to country readiness, when it comes to rollout, if we do not make progress on UHC, we'll struggle again. But finally, I also want to say that, you know, the reception which will now be hosted is also the launch event of the launch of the African Young Innovators for Health Award, which today launches its second edition. Because as we heard from the IPSF representative, you know, at the end of the day, our future is with the young. And I've seen at the first, you know, award for the young innovators, how much, you know, energy, how much vision there is in young people in Africa. And we celebrated that at the time at WIPO on it. But now please join me, join us. I think we all deserve a drink and some bites. Thank you very much for having joined us.
And thank you to our speakers, WHO, IFPMA, the 100-Day Ambitious Mission, and Gavi. Thank you.